Perfect. So it's been already quite a week. You completed your first set of tests, and I think that many students said that that was a positive experience. And then this week has been a lot of information. Skeletal system, and I'm going to be honest, I think also muscular system, there's just a lot of material. But that's my job to help to kind of process that in a way that hopefully doesn't feel so overwhelming. Um, so what I was gonna do, I was just quickly again gonna try to make sure that we take the pulse of the class, that everyone's in a good place, everyone's feeling okay. And then I was going to outline the assignments that we have for this week. This group that we have present on this session at the moment, I know you are amazing and you submit your work. If we have any students who are kind of confused or things come up, that confuse them in terms of what assignments are at what times, I really encourage them to keep an eye on those announcements. I use announcements heavily when I communicate any changes or when I communicate any due dates. So make sure you check on those as well. Like I said, I normally dedicate in my in-person classes quite some time for us to make sure that we're in a good place as a class. But on this online setting, you can share as much or as little as you wish. But I want to make sure that you do have a chance to let me know if there's something that I can do differently, if there's something that would be helpful or would be beneficial. My classes, I've been teaching this for quite a long time. They do tend to run in a certain manner, but it doesn't mean that I'm perfect in a way I teach. So I'm always open to hear from students. So if there's something that comes to mind, this is a good time, chat is a good time, but I'll also try to offer spaces in other ways. I think those discussion forums are a good place to share if you have any burning comments about what's working, what's not working. The other thing that I've been doing recently with my students is looking at some quotes and kind of using that to unbundle things that are working well and things where we can do better. But in the interest of time, I was going to skip it today unless someone really wants some Eastern wisdom to guide us. So here we have the assignments for this week. So I did have, and I noticed already an error there, so let me fix that right away. I did have on our initial setup an error there, which showed that you would have been working also on chapter 11 activities. That's absolutely not anything that you have to do. There was a typo in the due dates. This week, we're simply covering chapter 8 and chapter 9. Both chapters contain familiar elements that I think you already know, our quizzes, our practice anatomies, our discussion activities. So nothing too new on those ones. On chapter 9, we also do have the food for thought assignment, which follows very much what you've seen in the past or what you've seen in the past few weeks. Really, the key on those answering the food for thought assignments is to provide answer to everything that I've asked. Sometimes I do have a grading matrix to go with those. Sometimes I don't. So if the matrix is there, and I don't think that on this week's one, there is one, unless I get all of the sudden burst of energy and get it done this afternoon, which I doubt. Just try to answer to those questions. Remember that I do accept resubmissions. If you ever were like, oh, I did answer and I would like to add to that this and that fact, you can totally do so, and I will then regrade as long as you submit by the end of the week. We have discussions on both chapters. And for those discussions, like previously, I'm going to ask for 2 posts in total. The first one can be kind of your own driven in terms of summarizing the chapter content or anything else that you wish. But the second one should be a responsive to either to some of the prompts that I've thrown around or to one of your peers. So make sure you submit 2 posts if you do want full marks for those discussions on each forum. And those of you who go above and beyond, you do notice that I typically do tend to put extra credit for that as well. Um, I did want to share, and I'm kind of thinking at which point am I going to do that. I'll do it a little later on this presentation. There's been some really good sharing of tips and tricks on our discussion forum as well. So if you've come up with great mnemonics, if you're struggling to remember something, let others know. Likely there's someone who has tackled it. And if it's very quiet for a while, I'll step in and I'll share a way to remember things. But unfortunately, skeletal system, similarly as muscular system will be, there is a fair amount of just memorization. Remember that what's most important for me is that you understand why certain things are the way they are. So even though memorization is one strategy, I would encourage you to take good notes so you at least know where to find your answers if you're not memorizing everything. So that was kind of the leading into this week's material. And if it's okay with everyone present here, what I was going to do next was to simply jump into our lecture material. And I was going to propose that we kind of do like a nutshell version of highlighting the most important aspects of this week's lecture content. Again, as always, at any stage, feel free to just jump in. If you do have questions, if you have insights, thoughts, or just want to mention something. Was digging out some bones for us so we can refer to those as we go ahead. So let's start by talking a little bit about first in very general about skeletal systems, and then we'll start to unbundle the human skeleton in more detail. So the Greek word skeletos actually refers to the dried up body or mummy. And that really refers to the fact that we have had human remains for quite a long time, and it is the skeletons that typically survive. So that's where the terminology initially started, and that's the parts that people tend to remember. Um, I do want to highlight at this point, even though we're not doing comparative anatomy, we're simply focusing on humans, some possible differences in what type of skeletons we can see. And let me see if I can get a laser pointer out. We do have some animals, like humans, that have endoskeleton. So endoskeleton really refers to when the skeleton is inside the body, and then we have soft tissues on top of those bones. So that's what we'll be focusing, but I always think it's nice to put things in a bigger of a picture. So let's just, for kind of putting things in a perspective, have a look of a couple of other skeleton arrangements that we see in other forms of life. So exoskeleton refers to a skeleton that's on the outside of the body of an organism. Many insects are very good examples of that. So rather than having an internal skeleton, their skeleton is outside the body. And that skeleton is, for example, if you use bug spray, what gets dissolved with that bug spray. So sometimes I think that that's quite a brutal way to go for an animal, in sense of that their skeleton is being dissolved first before other parts. One analog that has helped my students in the past is to consider exoskeleton a little bit of like that armor that medieval soldiers or knights might have had. So rather than having an internal skeleton, it would be all of that armor on the outside of the body. We do see in some military applications, and we do see also in certain cases where people have, for example, injuries on their limb, that they might be wearing a synthetic exoskeleton to strengthen those limbs as well. The next type of skeleton that I wanted to mention is our hydroskeleton. So this is where the fluid pressure is keeping the animal's shape and giving that kind of a structure for it. We see earthworms are a good example of an animal that has a hydroskeleton. I think also starfish would be an example of an organism with a hydroskeleton. These hydroskeletons, obviously, if the animal ends up drying up, if they end up losing fluids, then that does no longer hold. But it is really these fluid pressures that keep the shape. Final skeleton type that I've listed here is something that you are actually probably quite familiar from your previous chapters, and that is our cytoskeleton. So cytoskeleton was a skeleton that we see on cells, providing that kind of structure, scaffolding to the cell, but also transportation pathways within the cell, thanks to different kinds of filaments and tubules, small structure that we see within the cell there as well. So I think that that orientates ourselves, that our focus is going to be solely on the endoskeleton of humans, but appreciating at least that there are other types of skeletons that we see and that we will be seeing in other forms of life. So having said that, let's take a step away just very briefly of the lecture material. And I wanted to share about the amazing discussion that I've been observing on our discussion forum. And there, some of your colleagues were kind of pondering how to remember differences between epicondyles and condyles and tuberosities and so on. Really coming up with mnemonics, whether it is that you created yourself or you refer to something that's already available. And anatomy is something that we've been studying for a long time. So there's a lot of mnemonics available for you. So try to work together, try to share your resources, and a big shout out for everyone involved in this conversation who came up with good ways of making sense about the differences between epicondyles and condyles and tuberosities and so on. Really, how you remember is not the crucial thing. The fact that you remember the differences, and normally when you develop your own mnemonic, you're guaranteed to remember. So those are things that I encourage you to do. So having said all that, let's jump back to the lecture material. So we're going to go through the skeleton in two parts. We're going to start first with the axial skeleton, and then we're going to go through the appendicular skeleton. Axial skeleton is going to be formed of 80 different bones, and we will focus on the most important ones of these. These bones collectively form the skull, the vertebral column, and the thoracic cage of your body. And if we really think about the axial skeleton, I think that rather than jumping to look at individual bones, it's sometimes helpful to have a look. Let's consider what's the function of axial skeleton, why we have it. And there's really three main functions that I can think of. So axial skeleton, first of all, forms our long axis of the body. So if you really want to oversimplify, and I think that engineering assignments often are very good examples of those, that they say, let's consider a group of penguins, and each penguin is a cylinder in shape. So we're going to do the same. We're going to consider that human body is cylindrical in shape. And we see that we have basically many systems, like your digestive system, passing through that cylinder, and material moves within that. So that's the long axis of the body. Our appendicular skeleton, our upper and lower limbs, they're useful, but they are not a necessity for staying alive or being alive. But most organs that we find within the long axis of the body, within that cylindrical shape, are. So axial skeleton really protects, let's jump on to the point 3, it protects many vital organs, such as your brain, your spinal cord, and your internal organs as well. I think the thoracic cavity is a particularly good example of protection for the heart, protection for the lungs, but similarly, our hips form this protective region for the organs, for example, that belong to the urinary and reproductive systems as well. And now let's have a look at the second bullet point that I have here. Long axis of the body, in addition to that, supports the many different parts that attach to that. So the long axis, the axial skeleton, supports your head, neck, and trunk, but it's also the attachment points for your upper and lower limbs that are worthwhile considerations here. So I had some fancy animations, but I think that's the biggest point of that. What I also wanted to talk about was then going through these different parts of the long axis one by one. And let's start with our skull. So skull is probably the most complex bony structure that we'll see in the body, composed of 22 bones in total. And we can divide these 22 bones into really two groups. So we're going to have our cranial bones and we're going to have our facial bones. So we're going to do that. I did want to at this point highlight that I've uploaded a lot of handouts on your Canvas course. These would be the similar handouts that I provide to my face-to-face students. So if you find that that matches with your learning style, that is something that you can do. You can download those handouts. You can color along on those as you review different bones or whatever works for your learning style. I also appreciate Jason for sharing on the discussion forum that he found some fairly inexpensive skeletons, and that is indeed the case. You'll find them on many online vendors, so that might be kind of handy to refer to those. Let me just see, my computer is acting up. I hope you're still able to see my screen. I think you are. If at any point you lose the connection or lose the view of what I'm talking about, do let me know. So having said that, let's see if we can get this working. Having said that, let's talk a little bit about the cranium in more detail. So cranium really is important for the fact that it encloses our brain within the cranial cavity or cranial vault. And it also provides us a place for the attachment of many muscles of the head and neck. And we can do kind of a division in terms of that we talk about the cranial vault forming the superior, lateral, posterior, and also forehead portions of that enclose the head within there. And then the base forms kind of the inferior portion of this cranial cavity. The facial bones that I showed partially listed here earlier on. Again, I do have a good handout of those. Remember that facial bones form the framework of the face. This really is where many special senses, special sense organs are contained. For example, for sight, taste, smell, passageways for air and food, and also the muscles of the facial expression. Important bones to know when we start unbundling the facial muscles. So all the work that you're putting in now is going to pay off at that point. So let's go back where we were earlier on talking about the cranium, cranial vault, and cranial base. And what I wanted to show with this picture is that at the base of the cranium, you'll see multiple different openings. And these openings are important for passageways of spinal cords from the brain or brainstem, for passageways for nerves running to different parts, passageways for blood vessels running to different parts, and so on. So in your more advanced classes, the expectation will be that you'll be actually learning each of these holes and what passes through them. But I think that on this class, if you're able to have a reference, you're able to refer to those holes, you're able to refer what could potentially pass through those holes, you're doing really well. Some of the very big ones that might be worthwhile to be aware of, you'll see the large hole at the base of the skull through which the spinal cord comes through. So this is known as our foramen magnum, which from Latin literally translates to a big hole. So that's a good example of that. What I also wanted to do was to talk about these sutures. Like a few people noted on the discussion forums, these weird wiggly lines that run on the surface of the skull. Well, these sutures are named in a way that more anatomy, more physiology you cover, easier it becomes. So let's start first with our coronal suture. Coronal suture is going to separate your frontal bone and your parietal bone. So it follows that coronal plane that we talked about when we were revising the major planes of the body. Sagittal suture instead is separating your skull, especially when it comes to the parietal bones, into the left and right side. So an important suture there as well. We have lambdoid suture, which separates the occipital bone from the rest. And what we see finally is going to be our squamous, or sometimes referred to squamosal suture, separating the temporal bone, so the bone on the side, from the parietal bone, and why not also from the occipital bone to a certain extent. So we see that these sutures are made of bone portions that interlock together and form a very, very rigid and very strong connection. These sutures only appear later on your development. During early development, we remember that the bones of the skull were very movable to facilitate the passageway through the birth canal, but also rapid growth of the brain. So we're seeing that a lot of our stories continue from one chapter to another. So here, like I said, we're seeing our facial bones. And again, whatever way helps you to memorize that, I encourage you to do so. But we're seeing a bunch of good bones that are worthwhile for us to know. I would highlight from there our mandible, the kind of U-shaped bone that forms the lower jaw. You'll see chin as well, and we'll unpack the mandible a little bit more in just a second. You'll also see other bones like our maxillary bones, two of those, one on each side, just above the jaw, forming the majority of the anterior face. You'll also see our zygomatic bones, one on each side. This is really where we see the zygomatic arch. So the high cheekbones that are characteristic for certain races, certain populations, are a consequence of the zygomatic arch of the zygomatic bone being very, very pronounced. Other bones that we might see, we, for example, see our nasal bone. So remember, most of your nose was cartilage, but at the very superior portion, there is a small amount that forms the bridge of the nose. And then there's a bunch of smaller bones, for example, your lacrimal, palatine, vomer, and inferior nasal conchae. These are worth of learning. And I believe that really a lot of that is going to be memorization. A lot of that is just going through it. So again, you do have full lecture videos available, but in the interest of time, I'll just leave it to that level at this time. So what I wanted to do with the mandible was to have a look at a few different parts of the mandible as the next discussion topic. So let's start with the angle of the mandible. Angle of the mandible is this corner that's really important point for muscles to attach. And you notice that males typically do have more pronounced mandible, angle of the mandible, and especially muscles that attach there than females, but there is variation both within males and females. We also see that the majority of the mandible is going to be called body of the mandible. This is a theme that you'll see again on major organs, major bones, that if there's a major portion of it, we call it body of that organ. The part above the mandible that heads upwards is known as the ramus of the mandible, and ramus of the mandible ends up with two ends, two kind of protrusions out of there that are separated by a notch in between. More anteriorly, we have our coronoid process, and more posteriorly, we have our condylar notch. A condylar notch is part that contributes to your temporomandibular joint. So the joint that was mentioned in our discussion forum, where the temporal bone comes together with the mandible and then allows your lower jaw to move. In certain patients, we see that there might be a poor fit at the TM joint, and I would be one example of those patients. So, for example, I have to be a little careful not to open my mouth super wide. There is a chance of the jawbone falling out of the socket. I did propose some discussion prompts also on the discussion space for about that. For example, to stabilize my temporomandibular joint, we decided that we're not going to do surgery. We'll approach in a more conservative manner. You can, for example, strengthen the bones that hold the TM joint together. So that's one way to do that. But in more serious cases, obviously, we then up what we were going to do in terms of treating and managing these. Other things that I wanted to mention as we're talking about important bones moving from the skull onwards. At the level of the neck, we actually see hyoid bone. Hyoid bone is located inferior to the mandible at the neck. What makes hyoid an interesting bone is that it doesn't articulate with any other bones. Most of the time, most of our bones do connect other bones, but hyoid bone is one of those ones that doesn't articulate. It's held in place with ligaments and other soft tissues. This is not in your exam, but because that's my background, I'll mention hyoid bone does have a forensic relevance. Oftentimes when someone gets strangled violently, hyoid bone can break. So that's something that we check on forensic settings. Not always. It is possible to strangle someone without breaking their hyoid bone. It is also possible to have hyoid bone broken, and even it not being strangulation, that's the cause of death. But it is something that we definitely pay attention as we're kind of forming that holistic view of what's happened with the remains that we're working on. I did want to mention at this point our paranasal sinuses. I anticipate that you'll be talking about paranasal sinuses a lot more in your BIO202. At least I highlight that for my students at that time. But sinus as a term referred to an empty space, as we've learned before. So paranasal sinuses are empty spaces within the skull around the nasal region. So we'll end up noticing that our skull is not solid bone, but we have these empty spaces. And these empty spaces are named after the bones where they're located. So we have maxillary sinuses within the maxillary bones on both sides. We have our frontal sinuses within the frontal bones above the eye socket on both sides. We also have something that's known as ethmoid sinuses or ethmoid labyrinth. That's the term that I prefer because it really is a series of interconnected empty spaces within the ethmoid bone, which is kind of further. We have to go into the nasal space and posterior nasal space. And then deeper, we'll also see sphenoid sinus within the sphenoid bone. So the purpose of these sinuses is somewhat debatable. We do know that they play a role in reducing the weight of the skull. So that reduces some of the weight from the muscles of the neck to keep the head upright. They do also contribute to the voice resonance. So your voice production is impacted by that. We'll also see that there are some theories. A friend of mine did his PhD about paranasal sinuses. So an argument that was put forward at that time was that maybe the paranasal sinuses serve a little bit similarly as the front of a car that's designed to collapse in head-on collision, so absorbing some of the forces. I'm going to be honest, I've not seen a lot of people falling so that their face would hit first. We typically try to prevent our fall, for example, by extending our arms or so on. And we do also know that sinuses do have a role in our immune system. We don't fully yet understand what it is, but that is something to keep on mind, which nicely shows us that inflammation of the sinus is known as sinusitis. So bunch of structures there. There is one more thing that I kind of just want to mention really, or maybe two more things really quickly as we're looking at the facial skeleton. So remember that orbit, the space around where the eyeball would be located and the muscles that control the eye is formed by bony framework. This really protects this structure as well. And the other thing that I wanted to highlight within the nose, once you look in there, you'll see actually nasal conchae. So nasal conchae are these kind of protrusions within there. And we'll talk about nasal conchae in a great extent in BIO202, how it expands the nasal cavity surface area so that we have as much of nasal mucosa interacting with the air as possible. So I just wanted to highlight those because I do think that they are worthwhile to consider as we're talking about these structures. Let me see if I can find the next one we'll talk about in a bit. So next, I wanted to talk about our vertebral column. Vertebral column, again, we see many different names in layman's language, more of a spinal column, or people talk about spine, running from the skull all the way to the pelvis. You might wonder why we have vertebral column. Well, there's a few different functions that I've highlighted here. Vertebral column is used to transmit the weight through your body. You'll, for example, see that your upper limbs, head, all connect rib cage to the vertebral column that then transmits the weight to the hips and then from there to the legs. So really important in that role. Also, vertebral column protects your spinal cord that runs within these structures. They're kind of enclosed by a bony protection. And this is really important if we think of injuries that might lead into damage of the spinal cord and into things like paralysis. So that's another thing to notice there. Importantly, thinking of our coming chapters like muscular system, but also some of the other bones, vertebral column offers many attachment points, not just attachment points for the muscles, but also, for example, to your ribs. So that is worthwhile as well to consider that vertebral column serves an important role in that as well. So all the ribs connect from one end to the vertebral column. And we'll talk about ribs in just a little bit more. I normally challenge my students to figure out what type of a bone your vertebrae would be. You'll see on the screen there, they are considered as irregular bones. There is a great amount of variation in your vertebrae, depending on what elevation you're looking at, what height you're looking at that. So vertebral column is made of 26 bones. We can divide them into regions. So we have 5 regions. We have cervical region, which covers cervical vertebrae 1 to 7. We have our thoracic region, which is really where we see, for example, the rib cage attaching to this area made of 12 vertebrae. So thoracic 1 to 12. And then we have our lumbar region at the lower back area made of 5 vertebrae. So lumbar 1 to 5. We also do have sacrum and coccyx. They start as 5 and 4 bones respectively, but they fuse together pretty early on, so we can treat them as structures on their own. Now, if you're thinking, how am I going to learn these vertebral column regions? One way how I tell my students and the number of vertebrae that you'll find on each is to consider that these are the times when people often eat, at least in certain cultures. So some people have their breakfast at 7, so 7 cervical vertebrae. Some people have their lunch at day at noon, so 12 thoracic vertebrae, and some people have their dinner early on in the afternoon at 5 o'clock, so 5 lumbar vertebrae. I don't know if that helps you, but that's one way to consider. Also, as we're looking at these vertebrae on this slide, and I think that I provided also this handout for you to kind of look and color if that's your way of learning, we see that there's distinct differences as we move down the vertebral column. The amount of weight that these vertebrae have to carry decreases or increases, and as a result, the size of the body on the vertebrae increases, so it can handle a lot more weight. So we'll see that there's some variation as we're working our way through. Other thing that I don't think that I normally talk too much about is the curvatures of the vertebrae. These curvatures are really important for us to be able to stand upright. So that's why newborns can't just immediately stand up and start walking or even crawling. They need to develop these curvatures. Newborn vertebral column is more of a C shape in its curvature. So there are developmental stages like lifting your head at 6 months, where the muscles are really strengthened and starting to crawl, and eventually standing up, average around 9 months, where we are forming and we have formed these curvatures. So when we look at the people, babies, children that are learning to walk, stand up, it looks very clumsy. But remember that there's a lot going on. They're not just learning the balance, but literally also changing curvature of your vertebral column. I did want to highlight a couple of parts of the vertebral column, and let's start with our intervertebral discs. These are kind of cushion-like pads that we see in between individual vertebrae. They serve to allow us to have more mobility as our vertebrae come together so that we can do movement, we can twist and bend our vertebral column. They also play an important role in shock absorption. Interestingly, these intervertebral discs over day, they receive stress, they receive pressure, and they do tend to squash a little bit. So you will see that some people, if you measure their height in the morning and you measure their height in the evening, there is difference because these intervertebral discs have gotten constricted during the day, and kind of that's where part of the height loss can be explained from. I think this was also mentioned on our discussion forum. Here we see really nice pictures showing us a herniated disc. So sometimes these discs, intervertebral discs, tend to slip out from where they should be, and they can end up pinching a nerve as a result. And the consequences can vary from slight to very severe discomfort, or even that nerve no longer working as it should be. So really, this can be for a few different reasons. Often physical trauma is behind there. Treatments involve exercising, massages, heats, painkillers, and in more extreme cases, also surgery to kind of relieve those nerves that might be affected. One of the things that I was kind of toying around, if someone's looking for a topic to write on the discussion forum, scoliosis might be an interesting one to ponder about a little. I don't think I do have a picture here of a single vertebrae. So let's talk about different parts of that. Remember that obviously we're gonna see that these differ, like I said, depending on which height, which level of the vertebral column we're looking, but we see some general structures. So the body is the part that's really the weight-bearing portion of the vertebrae, as you might be able to easily. It's ideally adapted for that. In addition, we do see, again, foramen. This is where our spinal cord would run within. We'll see these connections from the body to the posterior portions. The connection is known as peduncle. And we'll see transverse processes, so pointing transversely to the sides and also what's known as spinous process, kind of coming out more posterior. Um, it is worthwhile to notice that we do have a lot of articulating facets, as you can see on this picture, where various different structures connect. These ones that we see here would be ideal for your ribs to connect to then. So those are also worthwhile as you're reviewing bones, and if you have a chance to interact with, for example, skeletal model to keep on mind. So that's what I was going to say about the vertebral column, and I was going to move ahead and talk a little bit about the thoracic gauge. I do want to jump back, however, to this picture and highlight, if we're kind of comparing these different vertebrae, that the cervical vertebrae are very, very small and light in their structure. We'll actually see the very two first ones are going to be called atlas and axis, the most superior ones. And they're what allows your head movements, yes and no. So they're facilitating large amount of movement. As we move down towards the thoracic vertebrae, we see these vertebrae becoming larger, the body gets much more pronounced, and the articulating facets as well are really pronounced. On the lumbar region, really the bodies are incredibly massive of the vertebrae because they're dealing with a lot of weight and stress from there. Like I said, sacrum, 5 bones fused together, and then coccyx forming our tailbone. Really not serving any function these days, more of an evolutionary remnant from the previous history of our development. So sorry about jumping back and forth. Let's talk a little bit about thoracic gauge. So thoracic gauge attaches to the thoracic region of the vertebrae. The functions are multiple. We see that this really protects the vital organs inside the thoracic gauge, especially heart and lungs, but also supports your upper limbs and their attachment regions. So as we talk about appendicular skeleton, we'll see good examples of that. This is also where we see attachment sites for many muscles of the neck, back, chest, and shoulders. So useful in that sense. Let's unbundle from the thoracic gauge few different portions. I want to start with the sternum, so our flat chest bone or breastbone, as some call it. And there's really 3 parts to it that we want to highlight. First, we have our manubrium, which is the most superior part. This is where your collarbone, your clavicle attaches to. And we also see the middle part, which is the most prominent. So again, called body. A lot of your flat region here, when we do, for example, CPR, this is the portion that we aim to kind of get moving, pushing down, helping the heart, then even if it's not working, still see that movement of the blood. And then inferiorly, this tiny xiphoid process, pointy bit. Interestingly, on most people, this is not ossified until you turn about 40 years of old. And there's all kinds of weird clinical relevance. Let me see if I can example here, where we might see in certain patients pathology where it's pointing either forward or inwards. Obviously, this could become an issue if we're seeing that, for example, it ends up putting pressure on somewhere or potentially can interfere with organs on this area, but that's not very common. So that's our sternum. Let's talk a little bit about our ribs. So we're going to have 12 pairs of ribs, and we can divide ribs into true, false, and floating ribs. So the true ribs attach directly to the sternum. So there's a direct connection that we're going to see through the costal cartilage joining to the sternum. And there's 7 of those, so the 7 most superior ones. Then we're going to have 3 false ribs. These actually don't connect directly to the sternum. They join, fuse together first at the costal cartilage to form kind of a shared attachment point that then connects to the sternum. And finally, we have two floating ribs that are not attached at all, most inferiorly. We see that certain people who are really aiming for thin waist, there was a craze of people getting those removed. I think that that's maybe a little careless. Ribs are there for a reason, providing support, providing protection, but some did end up doing that. So I guess that I'll leave it to that about the um, rib cage as such. I was hoping I would have had a picture of an individual rib. I don't, but you will see on individual rib different parts as well. You'll see a head part, which is the more posterior one. You'll see the shaft, which is the majority of the rib, kind of a flat in appearance. You'll see the neck just after the head, and you'll see also the tubercles, these kind of bumps that help to connect, so knobs there. So that's what I wanted to mention about the ribs. And that brings us to talk about our appendicular skeleton. So let's have a look of appendicular skeleton a little bit. So appendicular skeleton is formed by our upper limbs. So upper limbs being made joining to the our axial skeleton through our scapula and clavicle, and also containing our lower limbs, which join to the axial skeleton through hips. So these junctions, really girdles are going to be important for us to consider. So pectoral girdle refers to your shoulder, and pelvic girdle then to your hip, bringing the upper and lower limb together. So let's talk a little bit about pectoral girdle first, so our shoulder. The bones that are involved in this region are going to be our scapula, our clavicle, and our humerus. So food there to know. I think I have here. So three important bones that we're going to talk. Humerus technically doesn't belong to the pectoral girdle, but it still contributes there. So we're going to talk about this. What this structure does, it really attaches the upper limb to the axial skeleton and serves really important muscle attachment sites. One of the things that's worthwhile to notice as you look at the upper limb and how these structures come together on your scapula and head of humerus, there's really a huge range of movement that we can do with these structures. That comes at the compromise that it is not incredibly stable joint, so it's not too hard to dislocate it. So we need soft tissues to hold that together. So that's something to notice there. If you wonder why this would be the case, I really do think that our evolution plays significant role. Moving to move on 2 legs rather than 4 freed our upper limbs and allowed us this ability to manipulate objects and so on. I'm trying to think what else to say. I think that about covers it. You could revise if you are interested of your chapter 1, the different kinds of movements that we can do at this level. We see huge range of movements: flexion, extension, abduction, adduction, circumduction. So really shoulder is ideal for large range of movement at the risk or compromise of its stability. So this is why, for example, rotator cuff muscles, when we talk about musculature of the shoulder, are going to be important. So let's look at, I was going to say a few words about clavicle. I don't know if I have a picture of it, but that's our collarbone, kind of S-shaped if you wish to imagine it. We do want to know that we have proximal and distal end. So proximal closer to the origin, distal further away. The proximal end articulates with the manubrium of the sternum that we just talked about, and distal end is then going to articulate with acromial process of the scapula. So really pronounced part there. Really, the role of the clavicle is that many muscles anchor here, for example, holding the scapula, and also scapula importantly transmits forces to and from the upper limb. So we did discuss on the discussion forum that oftentimes when people break bones as a result of trying to catch them when they fall, the weakest part of those series of bones that carry the forces is the clavicle. So it is possible to fracture that. So let's say a few words about the scapula. So our shoulder blade, a very thin triangular flat bone attaching to the rib cage on the dorsal side. So between the ribs 2 and 7, and we'll see three different borders. So superiorly, we'll see that it's very short and sharp border that we see. Medially, we see a edge that runs along the plane of the spine. And laterally, we'll see this coming up in kind of like an angle. This actually gives us three different angles. We have our superior angle, our inferior angle, and our lateral angle as well. So what parts of the scapula should we know? Well, there's few that I would like you to know. So the part where the head of humerus articulates, so the glenoid cavity, so the socket part of the shoulder joint. This is very, very small, very easy for the head of the humerus to act against. Other word that you sometimes see be describing these kind of depressions is fossa when we're referring to those. Other parts of the scapula, you'll see a spine. This is the ridge on the posterior side. And that's going to become important for us when we're talking about, for example, muscles or regions in relation to the spine. We'll also see our acromion, which is the most lateral projection of the scapula. This is where we would see, for example, acromioclavicular joint when the clavicle joining into it coming together. So clavicle attaches to it. You'll also see on the anterior side coracoid process, which is the one here. And this is going to be a projection where, for example, biceps brachii muscle would attach to. So often when you see bumps on the bones, those are important attachment points. What else could we say? We could highlight from here our subscapular notch at the superior border. This is an important part where nerves, for example, pass. Now, the term fossa that I mentioned when I talked about the glenoid cavity and how the head of the humerus articulated with it. The term fossa simply refers to an area or depression in medical language, anatomical language. So we'll see that we have supraspinous fossa, we have infraspinous fossa, underneath the spine, supraspinous, above the spine. We also have subscapular fossa, the region at the back. So here, supraspinous, infraspinous, and subscapular fossa. So that's, I guess, what I was wanting to mention about the scapula, and we're ready to move on to talk about the upper limb and the bones within there. So let's unbundle. There's 30 bones involved here, wrist and hand really forming majority of those 27. So we could go into great amount of detail, but I think if we get the basics, we're in a good place to work from there. So let's start with humerus. Humerus is the longest and largest bone of the upper limb, forming really the arm region. Some parts within the humerus to know. We see the head of the humerus. So the proximal end, that ball part that articulated in that glenohumeral joint with the glenoid cavity of the scapula. So that's worthwhile to know. We also saw our greater and lesser tubercle, which are really big bumps that we see at the proximal end. Really important attachment points for muscles. For example, many muscles of the rotator cuff attach here. We'll also see, interestingly, at this time that we can talk about anatomical neck of the humerus and surgical neck of the humerus. The anatomical neck separates the head of the humerus, whereas surgical neck is where the fractures often take. So sometimes we do like to joke, my background is as an anatomist, that anatomists and surgeons do not necessarily agree in some of the terminology. I think surgeons look from more practical point of view where injuries happen, whereas anatomists look for more of a proper language where the neck should be located. There's a bunch of other parts that we'll see also when we look at the humerus. We'll see a bump, deltoid tuberosity, about halfway down the shaft. This is where your deltoid muscle would attach to and kind of then wrap around the shoulder. You'll also see kind of depressions. So there's a radial groove running in there. This is where the radial nerve would run. And at the distal end, we'll then see trochlea, epicondyle, and capitulum. So important parts to know, important parts to go through, but really just kind of memorization largely there. Let's talk a little bit about the forearm bones. So one thing that we'll see when we look at how these bones do come together, humerus and then ulna and radius. Elbow joint is actually a very complex joint as we look at it. So there's a lot going on in forming the elbow joint. I don't know if I do too good of a job showing it on camera, but I'm sure your textbook will illustrate it as well. But there's really three bones coming together and forming this. In fact, if you wanted to be more precise, you could say that elbow is multiple joints that come together. The two bones that I wanted to talk about, forearm, are ulna. So ulna is the medial one of the two if you consider a person in an anatomical position. I always tell my students, if you try to remember, ulna is the pinky side and radius is the thumb side. The mnemonic that I give is right on for radius, thumbs up for that. So radius instead is the more lateral bone. From the ulna, we see a few different parts. We see olecranon process, this kind of a cup-like portion. This really is what wraps the trochlea of the humerus and helps with that. We see our coronoid process also articulating with the trochlea of the humerus. We'll see radial notch where the ulna and radius articulate, and we'll see the same also on the distal end. From the radius, like I said, the lateral of the two, some parts to know. We have a head portion that articulated both with the humerus and ulna. And then we have radial tuberosity, which is important part where the biceps attaches to as well to notice. When we move onwards, we'll see from the hand, we'll see the bones that make up the wrist. These are known as our carpal bones. There's 8 of those in total. If we wanted to go through those, we could. They are going to be our scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. I really think that these you benefit when you're learning these. Let's see. Really benefit if you have an access to a model to really kind of see them in more detail and interact with those. I offered, and the offer is still valid if someone wants to come to the college and look at the bones or look at the models of muscles. I can arrange a time that I'll meet you, or I'll at least make them available for you. But those were our carpal bones, wrist bones. Interestingly, this is not in your exam. We do see that there's actually a little bit of variation on the shape of those from one individual to another as well. Then we're going to see our metacarpals, which really form the palm region of the hand, 5 bones there. numbered from the thumb to the little finger, 1, 2, 3, 4, and 5. And then we see our phalanges, which are really the finger portions. We have 14 bones there, some to highlight. Pollex was the thumb, and digits were then the fingers 2 to 5. So those are worthwhile to notice from there. In the interest of time, I'm just going to move ahead and talk a little bit about the hips. So hips are, our pelvis is made of 3 main bones, and our sacrum, which you can see here, the sacrum. So let's have a look of those 3 bones. We have our ilium, which is the most superior one, ischium, which is the posterior and inferior bone, and then the pubis, which is the anterior. If you're having a hard time remembering those, a student told me to think of where your pubes are. That's the pubic bone. Ilium is the largest bone, and ischium is the bone that you would actually end up sitting on. So that's the sitting bone, if you wish to think of it that way. I'm just peeking. I don't have a better picture, so we'll use this. There's a few other structures within the hip bones to know. So acetabulum refers to the socket that's formed here for the head of the femur to join to. We'll also see the body of the ilium, the largest part. Iliac crest is the superior margin. And then we have, if we go backwards to this one, we'll see the opening of the hips, opening of the pelvis, where the baby's head would have to go through. So we do see some variation between males and females, especially for that fact that females do have to deliver the baby. Other structures that you might be familiar already with are pubic symphysis, joining the pubic bones together. This actually deattaches during giving birth. So literally bones do separate. Giving birth is quite an accomplishment as a male. I'm always amazed when I think of that. And then we have our pubic angle, how these come together on the lower aspect. And there's differences between males and females also on this area. So the pubic angle can help us to identify whether we're talking about male or female skeletal remains. So I think that's what I wanted to say about the pelvis. Let's talk a little bit about the lower limbs. So from the lower limbs, we have our femur. This is the only bone of the thigh, largest and strongest bone in the body. And there are a few parts for us to know from the femur as well. The head portion, which articulated with the acetabulum of the hip. We'll also see the neck portion, greater and lesser trochanter. So those are really important in terms of major muscle attachments. We do see sometimes the neck getting fractured. At the other end, we'll see again things like condyles and epicondyles and fossa in between of those. These are really sites. We'll see also here the site for the patella to articulate with. So let's move onwards, have a look of the leg portion. So we have our tibia and our fibula. Tibia is the medial bone, carries really all of the weight from the femur to the foot. And again, the language follows what you've seen before, our medial lateral condyles. We'll also see that tibia and fibula articulate against each other. Fibula was the lateral one, does not really carry weight as such. We have similar parts like the head and the lateral bumps to notice. From the foot, we'll see that our ankle bones are our tarsal bones, 7 of those to pay attention. Then we have our metatarsals, 5 bones, and our phalanges, 14, which really then form the end toes. Hallux is the term that we use to describe the big toe or great toe. So quite a bit of material there on chapter 8 for us to go through, but I think useful material. What I was going to do next was to go through very, very briefly our joints. I'm going to have to keep up a little bit of a speed so I have a chance to return the bones to the class that needs them. But let's have a look of different kinds of articulations that we have. So articulations refer to the sites where the bones come together. The function really is the movement, the mobility of our body and holding body together. So we are not having these joints detaching as well. These can be classified based on either structure or function. So we'll explore that a little bit. The structural classifications really we see our fibrous joints that don't move, where we see fibrous connective tissue connecting bones that are in close contact. For example, our sutures are really good examples of these that we just talked about, really these rigid interlocking joints. Our syndesmosis, bands of tissue connecting the two bones like tibia and fibula, and we'll see, for example, interosseous membrane and gomphosis are then peg in a socket joints like our teeth. We also see cartilage joints. There's is where the two bones come together. There's really no joint cavity. These are really immovable or moves very, very little, if any. I think growth plate is a good example of that. We'll also see, for example, the pubic symphysis or costal cartilages as good examples of those. I wanted to spend a little more time talking about synovial joints, which is probably the most complex of these. And these are really free moving joints. I encourage you, if you haven't had a chance to do so, you might want to draw it. That might be helpful. Let me just jump out of this presentation so I get my drawing tools out. Just give me a second. I'll reshare the screen. It's up. Yes, it does. So let's sketch real briefly. Let's sketch real briefly a typical kind of generalized synovial joint. Obviously, drawing on computer is not my forte, but I think that we can highlight some of the important parts of a synovial joint if we sketch it together. This is going to be overemphasized, the proportions, so don't get tripped out by that. But we see here two bones coming together on our synovial joint. And let's start by first defining our joint cavity. So this joint is surrounded by a joint cavity, which kind of forms the boundaries within which we'll see the internal structures of this synovial joint that we'll be looking at. So that's our joint cavity forming the framework for this synovial joint. Another thing that's worthwhile to notice that we do end up seeing at the ends of these bones that come together. Oh, I was afraid of that happening, somehow destroying adaptation on presentation tool has a tendency of doing these weird lines. We'll just remove that in a second. But where the bone ends would come together and interact, that would be really hard for the bone and cause often wear down of the bone. So instead, what we have there is our articular cartilages, which really form a nice smooth surface for these ends of the bones to join against each other and also kind of protect that underlying bone so there's no damage in that sense. Let me just tidy up here a little bit. Typically hyaline cartilage covering the ends of the bones, like we said. Let's add next our joint capsule. So let me get a highlighter that's going to make it easier. So our joint capsule is going to be really the actual capsule itself. And we would see that there's two layers if you study the joint capsule in more detail. We'll see there our fibrous layer, which is the more external one, and then our synovial membrane layer, which is the more internal one. But this really adds to the strength of these synovial joints, forming kind of a good structure, good surface. So let me finish on the other side if the computer decides to elaborate. We'll tidy off those messes from the drawing, but I do think that the joint capsule is a worthwhile structure for you to be aware because it contributes so much to the strength of, the synovial joints. So let's tidy those off. The next structure that I wanted to add to our diagram is actually going to be the fluid inside this joint cavity, if you wish. And this is going to be synovial fluid. So this fills all of this space that we see inside the joint cavity. This fluid serves two different purposes. It kind of lubricates these cartilages to slide against each other. But notice also that there's no direct blood vessels here within the capsule. So it is through this fluid that we're able to transport a lot of these materials to supply these structures with nutrients and other materials that they need as any other tissue to stay alive. So the synovial fluid is going to be an important one for us to recognize that's present there. Sometimes in certain medical settings, we'll also see that we might have issues there, too much, for example, of a synovial fluid, which then would cause us other considerations to kind of weigh how to treat, how to address that. The next thing that I wanted to add to our sketch of the synovial joint is going to be, oh, can I get it pulled up? Yes, I think I can, if I get the right tool. It's going to be a bunch of ligaments that really strengthen the structures that we see there. And these ligaments are, like we discussed, reinforcing the structure, adding the strength to there, making the synovial joint more stronger in that sense. So we'll just add them there and leave them there at this point. I wonder if I can tidy it up. I don't think I can. Other things that you could potentially see on a synovial joint, you could see blood vessels running, supplying these structures. So that's one thing to be aware, that we will see blood vessels not within the joint itself, but supplying them. And you would also see nerves running, supplying, kind of reinforcing, helping us to sense what's going on with that joint. So I would add those to our diagram as well. What else can we see? This is getting into more of weeds of the things. We'll also be probably likely to see some fat pads within these synovial joints. These fat pads serve as cushioning, helping in that sense. So you'll see those as well. One thing that I haven't mentioned that I really do want to add to this drawing, let's see if I can make it dark enough, is our articular discs within the synovial cavity itself. This helps us to ensure that we are kind of improving the fit and stabilizing this joint. We do sometimes see on these discs and also menisci here wear and tear over time. If anyone's a runner, you probably know that most runners over time end up wearing their joints, their knees. So that is something to keep on mind of kind of facing how much stress you put. Final thing that I wanted to add to this diagram, if I'm able to, let's see, is also a structure known as bursae. Bursae are these sacs of synovial fluid within the joint capsule itself. They help us by reducing friction there. So they're kind of useful structures in that sense as well. So I think that that completes our little sketch of a typical synovial joint. I know it was a little messy, but I think that we can survive from that. Moving onwards, we can see other classifications of the joints as well. And I think your textbook does a nice job of highlighting. We see, for example, plane joints where really we have gliding of the bone surfaces from each other. So that gives a name that sometimes they're just called gliding joints. We have also our hinge joints, and this works like the door hinges. And I think that we saw a really good example of that when we were exploring the elbow. What else could we see? We could see pivot joints where the ends really hold still, and then we still have the rotation around that. Condylar joints, this is kind of an oval socket, but not quite of a ball and socket fit. Saddle joints are joints where it's a sit and fits really well, but doesn't provide us unlimited movement, only movement on certain planes. And we talked about the ball and socket joint when we were talking about the shoulder and shoulder joints. So those would be some to be aware of when we talk about those. What else? I think that that brings us nicely to the end of the learning material on this chapter. We've covered a lot of ground, and I know that I've today kind of gone a little bit on a faster pace because I wanted to make sure that we at least to see some of the bones. But if anyone has any questions, I'm definitely here to help with those. But if you don't, that is literally all I had planned for today. I think I captured everyone who was present so that I'm able to give you extra credit for having been present. And as always, remember, even though this is an online course, it doesn't mean that you don't get support. I'm here very much to support. I'm here very much to answer questions. So don't hesitate to let me know how I can assist you. So that brings it to the very end of all that I had. I'm going to stop the recording at this point. If you have any questions, if you want to stay, if you want to chat, I'm very, very happy about that.